So the title of my case is There's More Than One Way to Close a Hole, and we've had a whole bunch of interesting cases on tricuspid valve and aortic valve and TMVR, and I'm going to go back to the original structural heart procedure, which is that most of us have done, which is PFO closure. So I've got two very brief cases. The first one is a 36-year-old who presented several years ago to an outside facility with a stroke. He had no prior medical history. It was a suspected paradoxical embolus. He had a markedly positive bubble study, and after a workup and a discussion with the team and the neurologist, he decided to proceed to PFO closure. The outside interventionalists attempted PFO closure, and I just included what they wrote in the report. They said the IVC was very tortuous. It appeared left-sided. They said they weren't able to advance the catheter into the SVC, but they could get the Swan-Ganz somewhere close. They tried multiple catheters and could never reach the PFO. So eventually, a contrast injection was performed, and they decided the patient did not have an IVC. And what this patient actually has, and I'll show you some images, is absence of the IVC with azygous continuation. And at this point, the interventionalists decided that they would abort the procedure and get a CT scan for better definition of the anatomy. And just for review, the azygous continuation of the IVC or absent IVC, in this case, the azygous drains kind of in the posterior portion near the diaphragm and comes up around and drains into your SVC, and so you actually do not have a normal IVC. And this is kind of a classic CT appearance. In this, you can see, normally you can see on the right there the aorta, and then on the left, that's the large azygous draining up and around into the SVC. And this is a 3D rendering, and you can see, so you can kind of see here the IVC as it comes, and as everyone knows, normally you would see it here on the right side. On this one, it's on the left side, draining posteriorly, and then would drain up into the SVC. So with this, the person doing this procedure decided to refer this patient to me, and this is just another CT scan. I'll let it play through one more time where you can see the contrast filling the SVC. You can see coming up right here, you can see a really nice picture of that azygous vein draining into the SVC. So after reviewing it and discussing the options, we decided on a right internal jugular access, and I'm sure some of you have attempted this. The TE had shown a prominent PFO. It did have somewhat of a tunnel appearance. You know, in my mind, an interesting point was you would think that since the PFO tunnel is directed inferiorly, that would perhaps be a protection, since we think most of these things are embolized from the legs, and with the absence of an IVC that this person wouldn't. But nonetheless, we decided to proceed to PFO closure. I accessed the right internal jugular, and it turned out to be quite difficult to pass through the PFO. I used multiple different catheters, and anytime I could get anything in, because of the tunnel, it would just flop right back into the right atrium. And so ultimately, we share a control room with one of our EP teams, and they were ended up, one of them, came over and said, "Hey, why don't you use one of our steerable quad EP catheters? It's going to work very well." Obviously, now having done a little more mitral procedures, I think we have a lot more tools. This was a time when I wasn't doing that. But the steerable quad EP catheter is a fairly cheap catheter. It worked very well, and then I was able to telescope an 8 French multi-purpose sheath into there and deliver a 25 millimeter cribiform device, as you can see here from the approach. And as in the upper left panel there, you can see just a different appearance than when you're normally deploying from the IVC, but a very nice result. So that was just a reminder that there is approximately 1 to 2% of people that do have alternative IVC anatomies. And as PFO closure grows, I think you need to be aware of this. If you're struggling along, it may be worthwhile to take an injection and see if you have an abnormal one. As I mentioned in this one, the azygous continuation of the IVC is the most common one, found in about 1 in 200 people. Again, just to remind you, there are 3 really other common approaches to PFO closure other than the normal one, which and those include the internal jugular approach, the axillary approach, and the hepatic approach. Obviously, if you're going to do the hepatic approach, you either need an experienced operator or some experience accessing a hepatic vein. So that was one of the first cases I did. In this most recent case, I debated about putting it on there because it's a case that did not go extremely well, but I thought it was worthwhile to show some of the difficulties you can get into when you're going from an alternative access. So this 62-year-old female presented with a basilar artery stroke. She was outside the window of TPA. She had a very complex course. She had cerebellar hemorrhage. She had a craniotomy. She was noted to have a very large PFO on or near presentation, and she also had bilateral large DVTs, and a filter was placed. They were going to remove the filter several weeks later after she'd been in the ICU, but they actually, and I'll show you some images, there was so much thrombus in her IVC that they decided that they did not want to remove the filter quite yet. She was discharged to a SNF on Lovenox and warfarin. One compounding factor is that on about day 5 of her hospital stay, she developed AFib, and so from the neurologist standpoint, then that was the cause of her stroke. She was going to remain on anticoagulation lifelong. However, 2 weeks later, when she presented with a therapeutic INR, she had terrible left lower extremity edema and pain, and the IR imaging demonstrated that her left leg vein had occluded, and they had planned a thrombectomy and wanted to remove a whole bunch of the IVC clot. And so after a long discussion, they decided to proceed to PFO closure to hopefully reduce her risk of a paradoxical embolus during that procedure. And here on the left, you can see this was the original picture where you can see the filter in place, but there is a large amount of thrombus still in the filter. And then in the right, on the right box there, you can see now her left leg is occluded. There may be some resolution in the thrombus in the filter, and I thought about going through the right leg, but given the thrombus burden, I decided at this point this would be another good case to come from the neck. So here's a look at her TE on the day of the procedure, and you get the sense that it's actually perhaps a small fenestrated ASD, maybe a little bit of a mobile septum. Again, coming from the neck, the wire easily passed in this case. I used a JR4, and then I ultimately put a safari wire in the left ventricle and decided because she was about to go for a thrombectomy, hopefully in the next week, that using something that would fill up the defect would be ideal to decrease her chances of embolizing something through. So I selected a 12 millimeter ASO device, and unfortunately that passed very easily into the left atrium, so I went up to a 16 millimeter device, and it appeared much more stable. These are just some pictures. You can see here on echo, it appears very stable. The device was released. I felt pretty good about the results. You can see she has a negative bubble study. I went out to write orders, and as I always do, I asked the tech to take one last x-ray, and then unfortunately the device had left, and that was an unfortunate thing. Fortunately, the device was easily retrieved from the descending aorta. It had embolized into the descending aorta. And after deciding what would be my best approach, I actually ended up deciding to come and get femoral access. So I actually did move through the IVC filter without difficulty from the right leg. And you can see here then that the defect opens up quite significantly. So I had really been fooled coming from the neck approach on how big the actual defect was. So I ended up putting a 20 millimeter ASO device in, and I did a very vigorous tug test and push test, and it turned out very well. And this is the image of the patient the next day. Approximately 4 days later, she went for a thrombectomy and had, I didn't include those images, but had a removal of her filter and a removal of a large amount of thrombus, and she'd done well. So I thought there were some key take-home points that with the recent trial results regarding PFO closure, I think the number of people going to PFO closure is definitely going to increase. So those of us that are doing that procedure need to have an alternative approach plan for those patients. And I would only caution you that you have to be very careful when you're planning and sizing those. You can easily be fooled when you're coming from the neck. And I guess the last piece is also that, as I did in that last case, most of these cases can easily be done through a filter. So thank you for your attention. Appreciate that.
Thank you, Lee. Great cases. Any questions from the audience?
I got two questions, really quick one. One is just technically, where do you end up putting the torque view once it's in? Do you leave it in the LA and before you deploy the LA disc, or do you actually, stabilize it in the LV, then pull it back? And because, as you advance the ASO through, it tends to shift quite a bit.
Yeah, both. I much rather deploy it in the LA if I can. The first case, it was much more difficult, and I had to be almost in the LV. But the second case, I guess there was a little more room. It wasn't as hard. And I think one of the key things there, like you said, is just having good wire position and knowing where your wire is as you unsheath it. And I think, you bring up another good point is one of the reasons I selected this device is I think if you're going to try and do this from the neck, the delivery system with this device is much more suitable to trying to deliver these fairly easily, at least from my experience. Have you done one with the cardioform? Has anybody done a cardioform from the neck? No?
It's a lot larger bore.
Yeah. You can use the Azygous actually as the delivery sheath. So if you have the steerable quad catheter, you can get that through, you can move the Azygous. At the time, and you could see by the fact that I used a cribiform device, I had not started in on MitraClip and anything, so I was just trying to find a way to get myself stable in the left atrium. So.
The exact same thing happened to us. Every time we try to advance a sheet, the wire just flopped, everything flopped back in the RA. But once you put the Azygous, you took that curve out, then you can actually just send all sorts of delivery catheters.
Yeah, we use in this case I used a multi-purpose which did the same thing. It got me into the left side. So, thank you.